Doctors Phil Koo and Dr. Gordon Brown for the topic of practice-changing applications of radiology and nuclear medicine and GU malignancies.
Thank you very much, Neil, for the invitation. It's an honor to be here, and congratulations on 10 years of a lot of great work with LUGPA. I look forward to seeing what the next 10 years holds. You know, when I was given this topic, it was very exciting. This idea of disruption is always very interesting. When I look at, here are my disclosures. When we think about disruption, and I think radiology being such a technology-driven specialty, we see disruption all the time, and we've had technologies that have improved our care, that have disrupted care. We also had PACs. And when I was actually training people, before I trained, people would tell me, are you sure you want to go into radiology? You know, you're not going to have a job because you're going to be outsourced. But that didn't happen. You know, artificial intelligence is the next thing. People are telling us now that computers are going to do our work. Maybe, but I think we adapt, and we've made a lot of changes to make this something that we work with rather than controls us. This idea of value has really impacted radiology. You know, we used to think that if you detected disease better and you were more accurate, you'd get reimbursed. But clearly, that's not the bar anymore. What the payers are telling us, you need to show us outcomes, and you need to show how you're going to control costs. And for a radiologist, that's really hard. And it's really presented a lot of challenges for our specialty. So disruption number one for your perspective is, I think radiology moving forward is more than just imaging, getting a test done, and getting a report back. It's changing. And the American College of Radiology is embracing this idea of imaging 3.0. There are a lot of other value add-ons that we provide: decision support tools, standardization, structured reports protocols, insulinoma management, data mining, care coordination. You know, a lot of these things are very exciting. We don't have time to go into it, but I think there are a lot of ways you could leverage imaging to help your practices grow as well. Artificial intelligence is more than just reading exams. Artificial intelligence can help with a lot of other things. So I think we're putting AI into too small of a box if that's all we're looking at. What I think is going to happen in the future is radiology, we're going to be data managers. We're going to look at big data. We're going to manage risks. We're not just going to focus on the time a patient's getting an imaging done. We're actually going to look at patients before to identify those patients who are at higher risk disease, find out those that need to be imaged, image them appropriately, identify findings on that, assign risk to that, and sort of go around in a circle continuously in order to manage risk, manage costs. So it's really big data that's going to help our practices in the future. And that's why the American College of Radiology, we created this new Data Science Institute that is going to drive that change and look into this and help us shape that policy as it moves forward. All right, so I'm going to show this short clip. We don't have volume.
And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
No, see, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to see things.
Hilarious. I heard this at a recent presentation recently, and it just really stuck with me. As a radiologist, everything I see is the nail in the head. And that's the way I approached my job. And what I realized is it's not. It's so much more complicated. And the more I learned about urology, the more I learned about prostate cancer, the more I realized that it's not about the nail sometimes. And it's really helped me become a better radiologist. I know it's crazy, but it has. And more importantly, it's helped me be a better husband. And my wife will attest to that. I try to listen more. It doesn't always happen. All right, so we're going to take a high-level view of things that I think are going to impact your practices in the next few years. Disruption number 2, prostate MRI. You know, we've talked about this a lot. I still think there isn't a ton of penetrance across the board in a lot of our practices, and Dr. Laporte talked about this as well. But this precision trial is something, full disclosure, I don't do prostate MR. I'm not a body radiologist, I'm a nuclear radiologist. This idea of prostate MR, this precision trial was published in the New England Journal of Medicine in May 2018, presented at the EAU earlier this year as well. Basically, just to summarize, it was a multi-center, randomized international prospective study of 500 men. It compared MRI with targeted biopsy versus a 12-core truss. And the targeted biopsy could be a cognitive biopsy, a fusion biopsy, anything. It just had to be targeted. Clinically significant cancers. So the MR group, 38% of the clinically significant cancers were detected versus 26. So it detected more clinically significant cancers. It also detected less clinically insignificant cancers, so it met both marks. On top of that, 28% of men avoided biopsy. And those that did get biopsy, less cores were taken, so you had less complications. Pretty impressive results if you just look at it from afar. It included academic and non-academic sites. They characterized the people performing the biopsies as those with moderate experience, so they weren't expert biopsy urologists. Here's where I think it gets a little tricky. The MRI concordance rate was only 78%. So 64 of those cases were sent to central readers. The concordance rate with expert readers is only 78%. But those that actually read it at the sites were experts themselves. They were doing over 300 MRIs per year for each reader, which is a lot of prostate MRs per year. So I think that's one of the limitations there. And path agreement was only 88% as well. So I think this provides some compelling data, and it's something that I think should spark a discussion in the various groups with regards to what is the role of prostate MRI and how does this fit with your entire strategy of detecting the disease. But I think it was something pretty interesting. So my recommendation when it comes to prostate MRI is find a role for prostate MR and MR-guided interventions. Doesn't mean everything has to be fusion. It could be cognitive. Cognitive was just as good in that study. Seek out a local radiologist willing to champion prostate MRI. And I think that's key to a lot of this, is you need someone with the face, you need that continuous feedback loop to really help you improve their practice. Disruption number 3, next generation imaging. So I think we've established that PET-CT using all these different radio tracers is better than any other tool we've had in the past. So we've moved on to that. The next part was the idea of how does it change management? And this is the study from Jerry Angerwall from Moss U that's in press right now in the Journal of Urology that clearly shows, on top of many other studies, that when you perform an Axiom PET-CT in these patients with biochemical recurrence, you are going to change management. 58% of those cases had change in management, and of those 58%, 77% were classified as a major change. And you can look at this and see what they classified as major versus minor. This is the detection rates with regards to PSA levels. You clearly see that as the PSA levels rise, the detection rates go up. And for this fluciclovine study, even at PSA levels between 0 and 0.5, detection rate was roughly around 30%. This is where we hear a lot about imaging, the PSMA-targeted agents. And when we talk about PSMA-targeted agents, there are multiple different types of PSMA-targeted agents. There's chemical differences between the different types that might have differences and create differences in performance, but we just sort of put them all in one bucket for now. Not FDA approved in the US, but it's going to come very shortly because we have this OSPREY trial. And this is the one trial I think we should all be on the lookout for. And this uses a F18-based PSMA agent. It's developed by Progenics Pharmaceuticals. They have a prospective trial right now looking at patients who are high risk at initial diagnosis and also patients who are biochemically recurrent. 377 patients. This is set to, I think, close in next month, December 2018, and hopefully read out soon. I think based on that, we're going to see data that leads to the FDA approval of a PSMA-based agent here in the US. So now that we've sort of established that this changes management, I think the big question that everyone has is how does this change management? And I think in the next few years, we're really going to see how using next generation imaging tools is going to change management that leads to better outcomes. And this is just sort of one early signal that it might lead to some outcome difference from this study that was reported at, I think it was EAU, that talked about time to initiation of ADT in patients where their oligometastatic disease was treated based on a choline PET-CT. wasn't statistically significant, but you saw a trend towards a delay in the time to initiation to ADT. Dr. Scherer showed data regarding that Medicare trial that's going to look at oligometastatic disease using various different types of PET imaging agents. And again, I think we're seeing more and more of that in the literature that's really going to help us understand better how we use imaging to lead to a better outcome. And that's going to be key, and that's going to help guide all of us as we make decisions in practice. There are limitations. We think about PSMA being this specific tool that lights up anything that's prostate cancer related. It's not true. PSMA is just a name for a peptide, glutamate carboxypeptidase 2, which is found in endothelial cells, found in neural cells, and this is an article that was recently published in the Journal of Nuclear Medicine that talks about increased uptake with PSMA in these ganglia. And oftentimes it's overcalled as metastatic disease when in reality it's just a normal finding. So it's important that your local radiology practice understands this and stays on top of the data, because the last thing you want to do is start chasing and treating things that really aren't disease. And here's just some examples of images that show these ganglia lighting up. This idea of stage migration is also something we need to think about, the Will Rogers effect. When the Okies left Oklahoma and moved to California, they raised the average intelligence level in both states. So you could see if we use these different imaging tools, we're just reassigning them to different groups. And you're taking a low-risk patient out of the M0, let's say the M0 CRPC, or higher-risk patient out of the M0 CRPC space, and putting them into the M1 CRPC space, where in that space they're actually lower risk because they probably only have low-volume metastatic disease. So this idea of sort of stratifying patients based on next-generation imaging could create better outcomes for both without doing anything. But we're seeing better designed trials that are going to overcome that. And long-term, better data is going to lead to more accurate data, which is going to lead to better outcomes and better decision-making for all of us as we enter in this phase of big data management. So future challenges, I think outcomes data is really the biggest thing, but we're seeing clear changes that are addressing that concern right now. Another challenge that we need to think about is all of a sudden you're going to have fluciclovine available, PSMA, which the first one is going to be 18F-DCF-PYL. We don't know what the name will be, the commercial name. But you're going to have choices. And the question becomes, how are you going to choose which NGI you're going to order? That's something we need to figure out. Will it be based on access? Probably. Costs? Probably. But I also think it's going to be more than that. I think if we create more trials that link specific diagnostic radiopharmaceuticals with a specific outcome, then we create this path with regards to how we know scientifically patients will benefit the most from these different radiopharmaceuticals. RADAR 3 was accepted and is in press right now, and I was honored to be a part of it with Dave Crawford, Neil Shore, other LUGPA members, Larry Kars-Raoul, which really provides our expert opinion with regards to how you incorporate next-generation imaging into your practice. It's available online right now, and it sort of builds on the whole purpose of RADAR 1 and gives recommendations for NGI for the future. I won't go into it, but feel free to look this up, and I think it provides a nice outline with regards to how you could approach it in the beginning. Recommendation number 1, find out what NGI tools you have available, figure out who your imaging experts are, because again, I don't think it's a commodity. I think you need to work and really improve quality actively, and the radiologists need to improve as well. That feedback loop is critical. Also, figure out ways that you can create actionable insights. Have a plan. If you're going to get this test, what are you going to do with the results? If it's positive, what are you going to do? If it's negative, what are you going to do? If it won't make a difference, there really is no point to pursuing it. All right, disruption number 4. I think this is probably the most important thing we're going to talk about today. It's the idea of therapeutic radiopharmaceuticals. Just on a side note, I-131 iobenguane, for those of you who have patients with metastatic pheos or paragangliomas, there's finally an FDA-approved treatment available using radiation, unsealed sources of radiation for patients that's based on I-131. Again, not a very common disease, but there is a treatment available. Moving on to radium-223, we're all relatively familiar with this now. It was approved by the FDA in 223. A year ago, we all received letters from the FDA talking about the increased level of fractures and deaths in patients who were enrolled in that ERA-223 trial that had radium-223 combined with abiraterone and prednisone. So we finally have the data with regard to that, and I'll provide that. That was released at ESMO a couple weeks ago. So this is the new warning label that's on the package insert that talks about a warning using radium-223 in combination with abiraterone and prednisone. This comes from Matt Smith, who presented at ESMO just a couple weeks ago, that showed that the overall survival was not different between those who received radium and abi versus those who received placebo with abiraterone. The hazard ratio was 1.195, and the p-value was not significant. So even though that first letter went out saying there was an increased risk of death, it didn't pan out in the final analysis. This is interesting. This is where the number of bone fractures were higher in those patients who did not receive a bone health agent while they were on that trial. Turns out a lot of those patients weren't on bone health agents. And I think about why, and I think maybe because in Alsimca, patients had that longer time to symptomatic skeletal event that people thought it was a bone protective agent when it actually wasn't. So in ERROR 223, fracture rates were higher. People weren't using the bone health agents. In the group of patients that were given bone health agents, you see the fractures go down significantly. So this was a failed trial, but as Chuck Ryan likes to say, this was a successful failure. And I think the lesson that we all can learn from this is that bone health is important, bone health protection is important, and there are a lot of signals that show that protecting the bones is important. So I think in the next year or so, we're going to be hearing more about this idea of protecting the bones. So again, it's a successful failure. I think there's a lot of lessons to be learned from that ERROR 223 trial, and there's other trials like PEACE-3 that use enzalutamide in combination with radium that will tell us more about combination therapies using radium-223, because I don't think we should throw away that idea because it still makes a lot of sense. Now we're moving on to theranostics. This is the golden promise of theranostics. If you look at A, there's a patient with metastatic prostate cancer. They're given 2 cycles of lutetium-177 PSMA. Their PSA levels aren't responding, and their imaging looks worse. But we know this because we track the PSA, and we're also doing an imaging study. At this point, you realize it's pointless to go forward with the lutetium-177 PSMA. And in this trial, the patient was switched to an actinium, an alpha particle, using PSMA. And after 3 doses, you basically see a radiographic complete response. PSA level less than 0.1. This is probably the most dramatic case that the authors had that they posted, but that's fine. But this is the promise of what theranostics could be for our prostate cancer patients. And I think it's very important for us to think about that. This is the phase 3 trial that Dr. Scherer was referring to that's sponsored by Endocyte. It has a design that's very similar to Alsimca that was used for the approval of radium-223. Randomized in a 2-to-1 ratio, patients receive lutetium-177 PSMA with standard of care versus placebo with standard of care. This started recruiting this past summer. From what I hear, recruitment's going well. The data looks pretty good. What I think the most interesting thing is they added this idea of radiographic progression-free survival as a primary endpoint. And they have a pre-planned interim analysis in late 2019 where they'll be able to look at rPFS as an endpoint. And based on that, if it's positive, I think they're probably going to apply for an NDA. So we may actually see this approved and available in the next year, maybe 2 years. Not a year, maybe 2 years. So it's exciting. We don't have to wait for an overall survival benefit here. An rPFS in late 2019 might be enough. Other trials going on concurrently, lutetium-177 versus cabazitaxel for third-line therapies. Phase 2 trial in Australia. Already there's trials being done at looking at how we sequence or layer these different drugs in the future. Fred Side at University of Montreal is actually in the process of opening up a lutetium versus docetaxel trial for second-line therapy. So again, this is very exciting, and I think it's something that we need to become comfortable with. How do I know this is going to be disruptive? How do I know it's going to happen? I have $6 billion reasons, 6 billion reasons why I know this is going to disrupt our practices. Novartis just 2 weeks ago announced their purchase of Endocyte for $2.1 billion, and that's based on that vision trial that they're promoting right now. 1 year ago, Novartis purchased AAA, Advanced Accelerator Applications, for $3.9 billion. So that's $6 billion right there that Novartis is investing into this theranostic space. AAA doesn't have an FDA-approved prostate cancer product, but they have a theranostic product for patients with metastatic neuroendocrine tumors that has shown great response in those patients. And again, they paid $3.9 billion for that. So clearly they're investing into this idea of radioligand therapies for the future. So my recommendation, number one, find out who is your authorized user. Do you have someone internally who's going to be able to administer this? There are a lot of licensing issues and regulatory issues, but who is that person? Do you need to go outside of your group to find that person? If you do, who will that person be? I think the best way to do that is to get comfortable using radium-223. It's a drug that's available right now, has a survival benefit, same hoops you have to jump through, and it sort of gets you into this idea of figuring out how you use these radiopharmaceuticals in your practice. I don't think it's very disruptive, actually, and the experience we've had with our referring physicians has been pretty positive. Potential disruptors. This idea of prostate artery embolization. I don't know if how many have heard about this, but it's something that interventional radiology is really looking into. And people now, I think it's being used more for BPH, but now they're looking at ways to chemoembolize using these different techniques. I hear it's very complicated, but I don't think it's necessarily going to be here in the next few years, but something that I think people are working on and looking at. For bladder cancer, we recently published a meta-analysis looking at these NGI imaging tools for bladder cancer, and basically we saw that there really was no role. It didn't perform any better or worse, moderate sensitivity and specificity with regards to metastatic disease. This is interesting because I think MRI is going to play a bigger role in bladder cancer patients. And this idea of standardized reporting, structured reporting with PIRADS is now extending into something else called VIRADS, so vesicle imaging reporting and data system. It's a nice way to sort of start the discussion with regards to how do we start interpreting bladder MR better. I think there are challenges involved with that, but I think there's going to be more attention paid to this area moving forward. Future challenges. Costs are going to be a huge issue. There's no question about it. But again, as long as we could prove that value and improve outcomes, I think there's a lot of potential there. Reimbursement. Right now, for diagnostic radiopharmaceuticals, the government oftentimes thinks of these radiopharmaceuticals as a supply as opposed to a drug. It's a very big difference. If it's a supply, you don't really get paid for the cost of the drug. And when these cost multiple $1,000s, your facility can end up losing a lot of money for each dose you actually purchase. Right now, there's legislation in the House or Senate that's trying to change that, where these diagnostic radiopharmaceuticals get changed and looked at as a drug, which makes sense because we're testing them like drugs. Why not pay for them like drugs? Because the same amount of R&D applies to these as they do to therapeutic drugs as well. And outcomes. And again, as long as we could tie these imaging tools and what we do to outcomes, I think we'll have success. So summary, value-based radiology can be your friend. And I think it's important to think about that as you grow your practices. Prostate MRI is a very important tool. I think there's room for all the biomarkers and MRI to work together. I think we're only scratching the surface. But precision is something I think we all need to discuss. Next generation imaging, it's better. It changes management. The last question is, how does it change outcomes? And we're almost there. Final point, targeted alpha therapies, radium, and radioligand therapies like lutetium-177 PSMA, they're here, they're coming. Be prepared and find ways to incorporate them into your advanced practice clinics, advanced prostate cancer clinics. Final recommendations, I think it's always changing. This idea of learning is important. We learned from the nail on the head that we should continue to listen, develop a plan, and really think about how you create integrated care delivery teams. I think there are different models to get to the same endpoint, but I think it's something worth pursuing. So thank you very much.
Dr. Koo, thank you. That was an excellent talk. I just wanted to touch briefly on one topic as it relates to our APC clinics. And most of us, I think, in the audience have APC clinics up and running. And considering the FDA approval of the novel therapeutics for management of patients with advanced prostate cancer really have been predicated on studies which utilize, for the most part, conventional imaging modalities. Can you give us your insights as to how we can make data-driven decisions and incorporate the use of advanced imaging in the management of these patient populations in our community practices?
Yeah, thank you for that question. I think that's a really tricky question because every single clinical trial that we have looking at therapeutics uses conventional imaging in their trial design. So how do we extrapolate that and make decisions? So if you look at Spartan and Prosper that look at M0 CRPC and the use of apalutamide and enzalutamide, we probably know that those patients probably had low volume metastatic disease, but because we were using bone scan and CT, we just couldn't see it. So how do we make informed decisions? I don't know. You know, and I think this goes back to Dr. Scher's point that the biology is different. As we push these things forward, you know, what we thought we knew about these therapies later in disease might not be true because the biology is different. So I think for now, it's, you know, you do your best and, you know, we form our opinions, but, you know, moving forward, we do need to find ways to incorporate these into our trials, and it's going to cost money, but, you know, I think it'll help us figure out what best to do.
Thank you so much. So great talk, great question. And so for just keep it on track and on time, let's bring up our next speaker and discuss.